started here as a medical director in 1998, and part of my job was to do some kind of quality improvement. The first thing we did was, in trying to improve our diabetes care, was to look at what the standards were. And then we saw, whoa, we've got some improvement needed here. And then we disseminated the results to our doctors. Of course, didn't believe it. They thought that they were doing just fine. But then they realized when the data was in front of them that, oh, there was room for improvement. We saw that we can, by paying attention to these things, we could really do a better job.
About 10 or 12 years ago, I got frustrated with the paper chart. It seemed that a great portion of the patient contact was spent trying to find things, particularly tests and things that were important or things that were several years old that had relevance to the medical problem now. So I hired my children. I have 3 girls, and they came in and organized my paper charts with files. So we spent a better part of a summer doing that, and then after all that time and effort, I realized this really was no better than what I had. So with that, we went to the electronic chart and computerized record keeping.
Afternoon.
Very well, doctor.
Good.
Typically, the schedule lightens up after September, and so we said, what could we do that would improve the schedule, bring more patients in, but at the same time improve the health of our patients? So we looked at doing a flu campaign. We wrote up a letter and said, you would be a good patient to get a flu shot, and it gave some details. The program worked quite well. The patients were pleased with it, and we continue to do that year after year.
The impetus to change really came from one of my newer partners. He sort of gave me a kick in the backside and said, wake up, we can improve this. And that started us moving. He had connections with the International Diabetes Center in Minnesota, was able to bring their materials and some of their expertise to us, and managed over a period of time to bring all of us together to review standards for care, to review our own data. This is Jean, who's one of our nurse practitioners, to brainstorm on how to adapt guidelines to our local reality with our local resources. So we adapted an existing guideline and promised ourselves to act more in concert with that. And then we went on and measured how we were doing.
Easy access was an idea which came from the Institute for Healthcare Improvement, and we took that and modified it for our use. So all of these ideas were there. We look at the literature, see what's going on, try to learn from who has done this in the past, and then adapt it to our needs, see where the issues are going to be for us, which is different. Every practice is different.
There's other outside forces that are helping us sustain our quality initiatives. For example, the peer review organizations for Medicare are evaluating the care of our diabetics. And Blue Cross in the state of Florida is now starting a pay-per-performance program to help actually give bonuses to physicians who maintain certain levels of quality.
It would have been difficult to have done as much as we have without external support. We had our own program ongoing when we joined an external consortium, but emotionally it's extraordinarily valuable to have other people that are doing likewise. The ability to email somebody with a question, the ability to have a meeting where you do compare your data, where you problem solve on issues is terrifically valuable.
Sustaining the gain is a challenge, and we started with a grant-driven program that expired basically in a year. And with that went that extra person to extract information and data from records. And quite honestly, it really foundered for a little while after that. I'd say about 6 months. The information gathering then fell back to me. As medical director and someone who was interested, I decided that I would figure out a way to maintain the flow of information, at least let people know how we're doing, and have spent the last 4 or 5 years really refining that process to make it more workable and actionable.
The biggest barrier with the electronic records were the cost initially, but once you're beyond that, the ongoing process of correcting glitches is probably the most frustrating things for me. If there's a software related issue, then I just simply have to be patient.
Anytime we've made change, we've always tried to do it on an incremental basis, try it out, see if it works, and then begin to expand it to other areas of the practice. For instance, when we did our easy access program of changing our appointments, we had just one practitioner change his schedule and watched and saw what happened over a period of weeks. And when it seemed to work, we then began to expand it to other practitioners in the practice.
We had done an audit a couple years ago to see how well we were doing for pneumococcal vaccine in seniors, and our results were about 50% of our seniors were getting pneumococcal vaccination, which actually is about the national average. But it seemed like we could certainly improve that, and so we had the medical records staff go through the charts for the next day, and as they were preparing them, identify who was over 65, and they'd put a stamp and a sticker on their chart to remind us, oh, they're over 65, check and see if they've had a pneumonia shot. We were able to show in our study that we could improve the vaccination of our patients from in the 50s to almost 80% with a simple sticker and a stamp.
The consortium that we're part of is led by the Medical University of South Carolina. They help us institute changes within the practice by way of utilizing the electronic records more efficiently, and then they provide the quality assessment on a regular basis. Some of the success that we have with coronary disease, atrial fibrillation, you expect to be good, and you are. Hello, how are you? But then in other areas, you find that you're not doing as well as you could or should, and so the combination of having nationally recognized standards of care, a vehicle that rates how effectively you do, puts you in the position of saying, okay, I need to do something about that.
One of the issues that we faced in improving the quality was documenting that patients had eye examinations, and this required getting a letter into the chart for diabetic patients. In order to do this, my partner wrote up a letter generically addressed to all the optometrists and ophthalmologists in town, saying this is really important part of quality care, and so that if you're treating our patients, we'd like at least a brief note saying that they've had their dilated eye exam and what your findings are. The result of that letter was that our numbers jumped up considerably, starting with about a 15% incidence of letters in the charts. When we did our first run-through with the QIO, we had jumped up well into the 70s at the follow-up.
For quality improvement leadership is critical. There's no question, because it's not going to bubble up from any one person coming up. It really has to have the stamp from the top that this is valuable, because it will mean changing how you do things, or shifting resources, or both.
Every 3 or 4 months, Dr. Balder will place in our box a sheet here that gives us my semi-annual hemoglobin A1C rates. It's just a good reminder for me, especially as I'm going through my training, to really have ingrained all those things that I really need to do to take care of my patients well. And without someone checking up regularly on those things can easily fall through the cracks.
Some of the things that help us along the way, we've had some really neat and talented individuals here who have developed simple, easy-to-use materials that help.
This is a big reminder for me. It's just really kind of a checklist that can be used to keep track of the healthcare maintenance things that have been done for our diabetic patients. This is a diabetes care card. This the patient takes with them, and so they can keep track of their own progress. I think by having one of these cards, it gives patients ownership of their problem, and so they feel like it is more of their problem. And then I think if they own the problem, they're more likely to make changes.
We began to look at changing our appointment schedule because we were not satisfied with what was going on. Open access means that when a patient calls and if they're ill, they're seen that same day. So we start out every day with about 100 open appointments, but it fills almost consistently every day. If a patient comes in for a cold, we will handle their diabetes at the same time, their hypertension, and any other chronic illnesses and conditions.
Okay, you take care of yourself, honey. You're welcome. Bye-bye.
We're really concerned about the whole patient.
The ability of the computer and data extraction, I think, is wonderful. And we know that by extracting the diabetics who have not been seen in 6 months, diabetics with a cholesterol over a certain level, a blood pressure over a certain level, that we've identified problem medical areas, and we can pull those people in and remedy that medical condition. When I discuss referral to a consultant or a specialist with the patient, within a minute or two I can generate a complete medical history. Specialists appreciate that and have come to rely on it.
We have staff meetings about every 6 to 8 weeks and sit down with the entire staff, talk about what's going on in the practice and look for opportunities for improvement. Whether they're large changes, small changes, try to get some feedback from the staff because they see things differently than the physicians see things, and often their input is valuable in making these changes.
When I have our staff meetings, I have a graph which I'll show, and there's not any doctors' names in particular, but their secret code number, which only they know. So they can look and see how they're doing compared to the group. Because I think competition helps. Most people always thought they did better than what the audit showed, but I think mostly they're happy with it because it helps them do a better job. And I think we're all in it to do a better job. The whole point of this is to try to make it easy.
The staff is very actively interested in competing with other practices that are in the consortium, because when we go to these meetings, you want to be the best. We have a graph that lists the basic parameters of the performance and the outcome data that's being collected. And when you get at or above the national benchmark, then you get a gold star. Not bonuses, not reimbursement, but a gold star was incredibly effective to get the staff involved with it. It works?
Yeah. We all here want to feel like we're doing better for our patients. And measurement really does help. And that, again, is what shook us up at the beginning, and it shakes people now. Now, acting on that is not necessarily easy. And there's a limit to how much one doc can do using his own or her own memory and pen and chart. But we're able to show that you can improve some things that way with commitment and then the tools to become more organized and do it.
Anthony? We had been doing flu campaigns each year for about 5 or 6 years. Then one summer I decided we weren't going to do it anymore. Middle of the flu season, I had a patient come in and tell me, Dr. Sobel, you didn't send the flu letter. And I said to her, but you've never gotten your flu shot. And she said to me, well, I always take the letter and go down to the senior center and get my flu shot down there because you charge $3 and the senior center is free. This is in the days before Medicare paid for flu shots. And I said, oh, great. But then she says to me, do you know Mrs. So-and-so, Mrs. So-and-so, and Mrs. So-and-so? And I said, yes. She said, well, I showed them the letter and told them how much I thought it was important that my doctor sent me a letter and was concerned about my health care. And now they come to you as patients. We've done it every year since then.
All physicians are seeing a turnover of patients based on switching insurance from this one to that one. And so we all have a certain rate of patients leaving the practice and going elsewhere. And it's gratifying that we have a very high rate of patients coming back saying, I'm willing to pay more out of pocket to see you because of the quality of care that you provide. And it's exactly that that allows us to bond with the patients, to have patient loyalty, and keeps us in business.
When you look at what we do versus sort of the broad swath of Medicaid places, we do pretty good. But we do strive to try to meet the measures no matter who people are, where they're from, and try to do better than average nationally.
When we expanded and got our ADA certification, one of the local insurers said that any practice that billed higher codes for diabetic patients who was ADA certified, they would not do any kind of focused review at all on these practices because they felt if these practices were delivering that level of care, they deserved to be reimbursed at a higher level. I think this is going to happen more and more.
It's very good reinforcement for the staff when I compare our results to like the NCQA results because we're doing as good or better a job. And the NCQA data is broken down for commercial, Medicare, and Medicaid. And even when we compare our numbers to commercial populations, we're better than they are.
The advice I would have for a physician approaching the aspect of quality is to decide on some area that is of interest and go at something small, something easy, achieve a measurable result, and then expand.
It turns out that doing quality improvement isn't hard. You can get on the internet and you can find out what standards of care are, It's easy to select patients' charts based on their age and their gender and to do simple audits. If you can recognize what you're doing well and what you can improve on, I think it gives you greater satisfaction.
Let's see here, your blood pressure, we've been checking it.
The patients who come in and pull out their care cards or take off their shoes and socks, those are the two things that really impress me the most right at the beginning of an encounter. That something is working, they value what we're doing for their health, or they value what they're doing for their health, and they understand that there's something to this that makes a difference. Yeah, we're actually doing something right together in this process.
The ability and recognition of quality outcome has basically kept me in medicine. You need some sense that, hey, this is worth it. I enjoy what I'm doing. I am getting the positive feedback. It's going to keep me going until I retire. So that's where it's at.